Namaste and welcome. It is my pleasure today to introduce to all of you Dr. Rakesh Gupta, a nephrologist from Dayton, Ohio. He has led a very large practice in nephrology in the Dayton area and has served as the president of the Kettering Hospital in Dayton, Ohio. After retirement, he has now decided to give his time to Ekal Vidyalaya Foundation of USA, and he has joined on the board as a director. He has been a strong supporter of Ekal for over 20 years, and now he's turning his attention to Arogya at Ekal. Dr. Gupta, welcome. Namaste.
Thank you, Ranjini ji, for a very warm and flattering introduction.
No, it's really true. And what I love is that you're using your medical background to actually make a big change in rural India through the Arogya Foundation of India. Could you tell all of us what exactly the Arogya Foundation of India is doing and how it's bringing health services to the last mile?
I'll try to do that, but I will start with a little more broader background that the society we are trying to serve in India, which is the bottom of the society people or tribal people, have multiple problems, and they cannot be improved without focusing on one of the biggest drag in their lives, which is healthcare. I've noticed repeatedly that through my repeated travels to India and small places, that one episode of ill health in their family pushes them backward many years in terms of borrowing the money and then supporting the family. We have, and fortunately, Ekal has also decided to develop these comprehensive development program, which has schools, meaning education, and secondly, the skill development, and third is Arogya, which is the health care for these people or helping the healthcare. So Arogya was involved for several years doing preventive healthcare, which is where the most money for the most bang for the buck is. And Arogya has been doing it, and I consider that to be almost like same as the schools, that education and healthcare education. But recently with COVID and other development of better internet connectivity in our rural areas in India, the opportunity has come that we for telemedicine in a big way. And everybody, including Government of India, is excited about telemedicine. Even PM Modi in this last budget of the government has focused on telemedicine and tried to do that. We fortunately have a bigger opportunity because we have a presence in the areas where government and other NGOs have difficulty reaching there. Yeah. So, over the last maybe 2 years, I've been involved in trying to push this. And we have a wonderful partnership with a telemedicine, one of the best association we have has it with the IntelliHealth, who are like head-to-head and shoulder-to-shoulder partner with our efforts. And that is also an NGO based in Johns Hopkins here in USA. So we have wonderful opportunities. We have already started a telemedicine program, including physician consultations in 4 sanches. And now we are planning to scale that up to a eventual goal over a period of few years to 35,000 villages. Each sanch is 30 villages. So we are started about 120 villages, and we have an opportunity to increase it and scale it up to 35,000 villages. And we are hoping that within this year, we can probably reach a few thousand villages.
Fantastic.
That's what we accept.
Fantastic. And I think the model that you have put in place is that we take a local young woman and train her to be an Arogya Sevika. And I think that, so in addition to providing, services into the villages, she's actually also able to get a little income. So the whole thing is surrounded around women empowerment as well. Am I right about that? Do you want to
Yes,
briefly talk about
absolutely right. That women empowerment, women learning technologies with mobile phones. So what the way it works is that now in one Sanch we have 15 sevikas which belong to that area and these were villages. We provide them blood pressure, blood sugar machines, phones, pulse oximeters, thermometers, etc. But most importantly, access to this software, which after the baseline survey uh, connects to the physician at the other end, which most of the physicians are volunteer physicians thus far, and they will answer their uh, questions as well as provide minimum basic uh, consultation as and uh, prescriptions
that?
through WhatsApp and all that. So this is the model. The Sevika is going to be trained.
Yeah.
So training is a very important part, and the quality of training, quality of data collection, and we are going to monitor how quickly the responses from the physician, whether the problem got resolved or not.
Yeah.
And believe it or not, when I travel, I've been told by my family members who are physicians in India that women and children in the villages, their health is frequently ignored.
Yeah.
And this is going to be a big tool for women's health, particularly because they they are at the mercy of their men in the
Yeah.
family or elders to be able to go to see a doctor, which are not available in these remote areas at all.
Right, right, right. So really bringing the health services to the last main, we know that not only it sounds like it empowers of course, the Sevikas because they are getting better trained, they're getting income, but really it's impacting the health of women and children in the rural areas, in which case I think that should be the focus of any organization, that'll really be impacting the future of the village itself. So that's fantastic. And now you were talking about a lot of work that happens in addition to providing, direct care through telemedicine and all of that. There's a lot of preventative work that is happening. Could you talk about that a little bit?
Yes, anemia, for example, is a big problem. So we will be checking hemoglobins periodically in this childbearing age women who have repeated pregnancies and become
Yeah.
anemic, which increases the mortality and morbidity. But also we also focusing on preventable waterborne and mosquito-borne diseases, and that is education,
Yeah.
which is already going on, but it's going to be enhanced through the telemedicine or electronic measures, which is going to be standardized. And all of this is fallen into the right place, because right now, when I traveled last time, even the remotest villages have accessibility for the uh, data through
Yeah.
the mobile phone. And even for these women in the villages to learn using mobile phone and from one to the next teaching,
Yeah.
that I consider that even to be a wonderful opportunity for us to, because women are not given the mobile phone in the family,
Right, right, right,
unless they ask for it and repeatedly bug for it, and if they were
right,
never touched the mobile phone.
right.
So I think the digital revolution is also, we are contributing a little bit towards that as well, in my
Super.
view.
Absolutely, absolutely. And what I was very impressed when I was on one of those calls, that where preventative health work has been going on for a long time. We found the data that the women, people are actually boiling the water. People are following hygiene comments, and 100% of the village was drinking boiled water. And I think that is an testament to the fact that education does work. And I think that is a fantastic thing
Especially
to see.
repeated education,
Repeated
especially
education.
repeated education. And in our model is also, what we have come up with is that yes, we provide the training, we provide the software, we provide the equipment, but we are hoping that after with the small incentives of each time the patient is seen to the
Yeah.
Sevika directly, we don't get any money. And maybe when she checks the blood pressure, the villager gives a small amount of money, or when she checks the blood sugar, a small amount of income is generated, that she will be able to sustain herself. And for most of us, we did not realize until we started working in this area that even today in villages, even high blood pressure, diabetes are becoming rapidly prevalent
Yeah.
there. which is going to lead to stroke and a lot of other heart attacks and all those sudden, death demises and in the family of a earning member and all that. So I think this is a very important step.
Yeah.
Fortunately, the current technology and COVID has accelerated it. It was, which is we are grateful for, actually, in some ways.
Yeah, of course, of course, of course, of course. And actually, I was going to ask you another question, which is that in addition to telehealth, there's also a small pilot, I think, going on with another thing to do some lab testing. Would you want to talk about that?
Yes. So in parallel, we are also doing an experiment with a company called Jarvix, with we call it Porta Clinic in near Banaras in one Sanch, where we will not only be doing all what we are doing with telehealth and telemedicine, but in addition, there is going to be some labs being basic blood work can be done in those areas with the help of a person who will have a motorbike, and there's a dedicated physician. So we're going to look into that as well to see how much does it additional cost. And I don't know if you want me to talk about the cost of this program or not.
If you want to briefly outline, I mean, maybe in 30 seconds, if you want to talk about both of the programs.
The cost is really the Ekal's brilliance is bringing the cost down and avoid, and with the help of a lot of volunteer time and hours, which we don't count as cost, bring the cost down. So the cost is really the way we have, it's $15,000 per Sanch per year, which the amount of lives we cover and help them turns out to be almost $1 per day per villager, and that is a very, very minimal expense. If we can,
actually, $1 per year we are talking about, right?
Per year.
$1 per year
per villager per year.
Yeah,
$1 per villager per year.
That's amazing. That's such a low cost.
Roughly around that. US dollar. Yeah.
So supported by lots of course, lots of volunteer effort. So it's really low cost to make a dramatic difference. I see that.
The doctors are not charging anything, and the training part is free. So there's a huge amount of, I mean, if you add all of that, we're actually, for each dollar we spent in this, we're getting at least $3 or $4, through these indirect costs as a volunteer hours.
So that's a huge leverage, and so certainly it makes a big difference. So now I know that during the pandemic, this was a very important, facility we provided with having a lifeline where people could call in. We promoted vaccinations. We did a lot of information thing. Moving forward, where are you seeing Arogya Foundation's work focus?
So we are maintaining the helpline whereby they can call in nationally to this number and somebody will respond. Because a lot of time it's also questions. Many times what happens is these people go to see a doctor, but in India, doctors don't tell them anything. So especially there are many of these healthcare conditions are exaggerated, or because of emotional issues, psychological issues, lack of understanding, concern and worries about uncertainty, what will happen if I don't do this. So all of these questions, we are hoping that we will also have a lifeline, helpline, which will be national, which can answer some of those questions. During COVID, it was profoundly helpful because people were, it avoided unnecessary flooding of these people to the hospital and making them even overburdened. So we have continued that since then, and during COVID we also provided masks and a lot of other educational things. So it was all started from there, and now it's building up towards this.
Right. So hopefully in a few, a couple of years, we are hoping to get to 35,000 villages, which is amazing because that's like 35 million people that we are affecting. And so I really, really look forward to that. So I think for what kind of help are you looking from our donor community?
Well, we think that we basically financial resources all we can provide within the USA. And I
Yeah.
think if we are looking for people, we are to sponsor these Sanch, which is $15,000 per year,
Yeah.
which is $1 per villager per year for healthcare. And that saves the villager a lot of money,
Yeah.
because not only they don't lose the wages when they have to go to the city,
Yeah.
it provides timely uh, healthcare needs, which otherwise delayed
Yeah.
cost them more,
Yeah.
as well as some exploitation which happens in the cities when they go for unnecessary testing, etc. So I
Right.
think this is a profound implication from this. But I think we are looking for $15,000 per Sanch
That's for
per
30
year
villages,
for
$15,000 for
30
30
villages, for
villages.
30 villages, for 30
And that,
villages.
yeah,
Yes. And then, we eventually need to reach to 35,000 villages, which means almost 1,000 of those Sanch. And currently we only have, uh, you know, four Sanch on funding for maybe 10 or 20. So there's a huge room for people to contribute. The caveat there is that we cannot start any we can start a Sanch in the donors area, but we cannot start every village.
right,
Yeah,
right,
it
right.
has to be a cluster of 30 villages nearby.
So that is really fantastic. Dollar a year to provide quality healthcare to the last mile. I think this is really, really a fantastic effort, fantastic addition to what we are doing already, which is bringing, education and Gramothan skill development to the village. And now we are adding Arogya, health, which will really dramatically impact, particularly the women and children in the villages. So, and I know that Rakesh ji, you're constantly working with the ground. Every week, I know you have a meeting with them to ensure that the progress is happening in the right manner. So we salute you for your commitment, and we sincerely thank you for all the volunteering you're doing for Arogya Foundation of India, and look forward to seeing those 35,000 villages and more really get health services that they so desperately need. Thank you so much, Rakesh ji. Namaste.
Namaste. Thank you, Ranjini ji.